Good afternoon from Lisbon, Portugal. This is Dr. John Bennett, head of Neurosurgical TV. We have the pleasure of having a webcast done by Dr. Kabulo, Dieu Kabulo. He's going to talk about hamartomas of the hypothalamus. Before we turn it over to Dr. Kabulo, let's briefly introduce the panel. Hello, Ulrich.
Yeah, thank you. I'm Ulrich Sidney. I'm a research associate at the program of global surgery at Harvard. Nice to meet you all.
Leader of this group. Hello, Igor. How are you doing?
Hello. My name is Nicha Igor. I'm originally of Cameroon. I'm year one in neurosurgery at Abidjan University.
Year one, just starting the journey. Huh? Great. Okay, Dylan.
Hello, everyone. I'm Dylan Diofak, general practitioner from Cameroon. Nice to meet you all.
Very good. Thanks, Dylan. Zolo.
Hello, everyone. I am Zolo Ivan. I am a fifth-year medical student from the University of Boye in Cameroon. I'm a member of the Association of Future African Neurosurgeons, and I'm happy to be here. Thank you.
Thanks for coming, Zolo. And first, Mohammed, are you there? Could you please introduce yourself if you are? Okay, Dr. Kabulo, thank you very much, and it's all yours.
So, thank you to Ulrich for that great presentation on simple anatomy of the hypothalamus. That was a thorough presentation. So I'm just going to give you a brief presentation, a few slides on hypothalamic hamartomas. I'll just go on general things. I'm not going deep. So first, we lost one of the great presidents in Africa, Comrade Robert Mugabe. So we are crying, we are mourning Mugabe these days. Many presidents from Africa are here. So may he rest in peace. Okay, then we go back to our hamartoma. Hamartoma, that word is coming from Greek, hamasia, which means fold, or I'm sorry. Sorry, let me do this. The picture is obstructing my presentation, so I wanted to bring it up there. Okay, so hamartoma is coming from Greek, hamasia, which means fault or defect, and oma denoting a tumor or neoplasm. So it's a benign, non-cancerous tumor-like malformation, which is made up of an abnormal mixture of cells and tissues found in an area of the body where growth occurs. So other authors, they consider it as a developmental error, which can occur at a number of sites in the body. But in the literature, they describe several examples of hamartomas, including the following. Usually, hamartoma resembles a neoplasm, but in most cases, it does not show any tendency to evolve into one. So cases of neoplastic evolution have occurred with these lesions. Examples are chondrosarcomas arising in osteochondromas and the neurofibrosarcomas arising in patients with von Recklinghausen disease. So in addition, neoplasms can be associated with hamartomas without directly arising from them. Examples are fibromas of the ovary and malignant ovarian tumors arising in patients with Page-Jeghers syndrome. So hamartomas should be distinguished from choristomas because hamartomas, they are composed with tissues that are normally present at that given site where they are arising. Whereas the choristoma, you get those malformations of tissue that are not normally found at that site. This is where they are talking about heterotopia. So when you're saying hamartomas, choristomas, it's heterotopia. So you get malformations of tissues which are normally found at that site. They are coming from another place, like microscopically normal tissues derived from germ cells layers foreign to that body. So apart from this one, since we are talking about hamartomas or choristomas, there is also what is called teratoma. So teratoma have been designated as benign tumors that contain representative component of all three germinal layers. So teratoma, it's also a tumor, but made up of several different types of tissues, such as hair, muscles, teeth, or bones, and they typically form in the ovary, testicle, tail bones, and also less commonly in other parts of the bodies, like in the brain. And when they come in the brain, they're always midline, especially in the pineal region, and also in around the cellar region. So the hamartomas, they say, okay, hamartomas, choristomas, and gangliocytomas, these types of lesions arising in the hypothalamus are known as hypothalamic hamartomas. And those arising in the cellar without attachment to the hypothalamus are called choristomas. So hypothalamic hamartomas, they are also known as diencephalic hamartomas or hamartomas of the tuber cinereum. They are very rare. They are non-neoplastic congenital malformations arising from inferior hypothalamus or from the tuber cinereum, which is on the floor of the third ventricle between the infundibulum stalk and the mammillary bodies. So they also may occur as part of this syndrome. They are saying sporadic cases are there, but 5% of, many of them they are sporadic, but 5% they may be associated with Pallister-Hall syndrome, which is a genetic autosomal dominant inherited defect where this gene is participating in the normal shaping of many organs. So in this syndrome, you can also get hamartomas. So in terms of clinical findings, there are many things. There are few things we can get with hamartomas, but there are specific types of seizures you can get in this hypothalamic hamartomas. The type of seizures, there is what is called gelastic seizures, which is a brief episode of unprovoked laughter. And they are the most characteristic type of, and are the earliest seizures manifestation. They present up to 92% of patients, but they are not pathognomonic because a neocortical origin has been described, also neocortical origin of gelastic seizures. They are resistant to medical management and can lead to cognitive behavioral deficit. So these are a few videos showing you, unfortunately, I don't know that side if you can see better the video. They are showing children with gelastic seizures. Okay, I think the volume is not there. Can you see the video?
Yes,
Yeah,
yes, we can.
We can see.
Yeah, it's unprovoked laughter. You just see a baby who was sleeping or playing starting to laugh, and usually it's rare to have loss of consciousness. So apart from gelastic seizures, we have also what is called epileptic encephalopathy, whereby it is coming after the gelastic seizures. So the first to arrive in terms of seizures is gelastic seizures. But when they are there, they are increasing in frequency. Then other types of seizures can also occur, like complex partial seizures, tonic-clonic seizures, secondarily generalized seizures, and this called drop attacks. The drop attacks are sudden falls without loss of consciousness that are not precipitated by specific stimulus. And usually they occur with abrupt onset and without warming sign. And they are followed by a rapid return to baseline. That's how they come to drop seizures. So the epileptic encephalopathy, this phase is associated with marked deterioration of cognitive and behavioral abilities. And they develop in 52% by a mean age of 7 years. So another sign apart from seizures with the hypothalamic hamartomas, you can get precocious puberty, which is believed to be due to release of gonadotrophin release hormone found within hamartoma cells. And the hamartomas are the most common CNS tumors to cause precocious puberty, though there are also other causes, including other brain tumors, hydrocephalus, inflammation, and so on. So apart from seizures, apart from precocious puberty, you can also get developmental delay when you have hypothalamic hamartomas. And that delay is primarily in patients with seizures disorder, and the severity correlates with duration of the seizure. The more you get the seizure, which are lasting, the more you get developmental delay. And 56% of patients have borderline intellectual function, mental retardation. And also you can get behavioral disturbances like aggressive behavior, like rage attack, that. Then other things you might get clinically, there might be variety of autonomic disturbances like abnormalities of thermoregulation, since it is touching the hypothalamus. You can get behavioral disorders like we mentioned before, somnolence and hyperphagia. Sometimes you can get hemiparesis or nystagmus. And also occasionally, since this occurs usually in children, you get also those children may present with cachexia. So radiologically, on plain X-ray of the skull base, usually it's unremarkable. Of course, you can see erosion of the dorsum celli, but in most cases, it's unremarkable. And on CT scan, you get, it will be isodense and not taking contrast. You see just a supracellular region, a supracellular mass, or interpeduncular cysternal mass, which is isodense and non-enhancing. On MRI, on T1 and T2, they are iso-intense, but others are saying on T2, they might be slightly hyper-intense. So you see that iso-intense mass, which is attached to the tuberous cinereum or posterometer to hypothalamus. Then the lesion may lie entirely within the substance of the thalamus and may therefore be easily missed if very small. Then according to pathology, there are two subtypes. There is the pedunculated and the intrathalamic. Pedunculated or parahypothalamic, it is a narrower base attached to the floor of the hypothalamus, and it is not arising within the hypothalamus. With this lesion, there is no distortion of the third ventricle, and generally it is associated with precocious puberty more than seizures. But the intrathalamic or sessile, this one is within the hypothalamus, and you see that there is distortion of the third ventricle. So it is a broad attachment, like pedunculated means small base, sessile, broad base. And the intrathalamic, it's more often associated with seizures. And 66% have developmental delay and 50% have precocious puberty. So microscopic pathology, you will see clusters of disorganized small neurons surrounded by large pyramidal-like neurons in a astrocyte-rich neuropil, in contrast to the usual ganglion cells surrounded by oligodendrocytes found in the hypothalamus. So hamartomas usually, like I mentioned again, resemble normal gray matter, but they contain neurons which are indistinguishable from normal hypothalamic neurons and may contain secretory granules. Those are the secretory granules which are producing luteinizing hormones, releasing factors. Also, those granules, they contain also beta endorphin, they contain corticotrophin, releasing factors, and oxytocin. But on immunohistochemistry, it is positive for hypothalamic hormones in the neurons of these lesions. So the natural history is usually unfavorable in the majority of patients because of behavioral symptoms. So interestingly, reversal of these behavioral symptoms after radiosurgery seems to begin even before complete cessation of the seizures. Then in terms of treatment, precocious puberty usually respond well to GnRH analogs. And indications for surgery. We go for surgery only when there is a precocious puberty that fails to respond to medical therapy. You also go for surgery when you have seizures that cannot be adequately controlled medically, or post-seizure control is related to completeness of resection. And the third indication is neurologic deficit from mass effect of the tumor. Once you get a neurological deficit attributable to the lesion, you have to go surgically. And options for surgery, it's according to the types of the hamartoma. When you have the pedunculated one, you can go through subtemporal, subfrontal, or pterional approach, or orbitozygomatic approach, which is the most commonly recommended. And here the risk is cranial neuropathy, because remember, before you reach there, you have to cross many cranial nerves on your way. So if it's sessile or intrathalamic, usually they prefer to do a transcallosal anterior interphoneal approach. And the risk here is memory impairment, because you might injure the phones. And also there is another approach, neuroendoscopic approach, which is considered when the hamartoma is less than 1.5 centimeter of diameter. And the risk here, 20% incidence of thalamic cerebrovascular injury. So stereostatic radiosurgery, they're saying in small series, 3A outcome showed improvement similar to surgical resection with less neurological and endocrinologic mobility. This is why other authors are saying it is not important to do it. It's better to go for surgery than this one, because almost the same result. But Ramamurthy is saying it's even not indicated. But those who are accepting stereostatic radiosurgery are saying you have to go there when especially the tumor is very small, sessile lesions. And also when you're going, after doing subtotal resection, you go for surgery, you do subtotal resection, then the remaining you do stereostatic radiosurgery. And also when patient is refusing surgery, or the patient is not candidate to surgery. And surgery is indicated in most symptomatic patients. Like I was saying, according to Ramamurthy, they're saying radiotherapy is ineffective in treatment of these lesions. So surgical treatment is useful to confirm the diagnosis. That's the main thing. And also to regress or abolish precocious sexual features and skeletal growth. They are saying if you go and remove even a part of the tumor, you might improve, you might sort out the problem of precocious puberty. But there are also some drugs such as medroxyprogesterone acetate or cyproterone acetate, which have been used to inhibit gonadotropin production in patients with precocious puberty. So apart from surgical treatment, you can also use drugs. But if they fail, then you go again for surgery. Thank you for being there. These are my references. And once more, RIP to Mugabe. Thank you.
Thank you very much, Dr. Kabulo. Sorry to hear about the passing of the president. Excellent presentation. Thanks a lot for taking the time on probably one of your days off. I'd like to open it up for comments or questions from the panel.
Thank you, Dr. Kabulo. Thank you so much. That was very interesting and a very good compliment to what we just had. Thanks.
You're welcome.
Any other comments or questions? Igor, Mohammed, Dylan, Zolo? Come on, guys, wake up. There you go, Zolo. Zolo is awake.
Yeah, I'm always awake. Okay, thank you very much, Dr. Kabulo, for the presentation. Thank you very much for the presentation. It was really nice and quite comprehensive. So thank you very much for the presentation. Thank you. I have no question.
Thanks, Zolo. Thanks for coming. Okay, unless Igor or Mohammed has something to say. Dylan, any comments or questions?
Hey.
Go ahead, Dylan.
Yeah, hello.
Yes, go ahead, Dylan.
Yeah, thanks, Dr. Kabulo, for the presentation. It was really good. I wanted to know, is it possible to make any correlation between the type of hypothalamic tumor and the clinical presentation of the patient? So, like, for example, is there something, a typical correlation between the nature of the tumor and the clinical presentation of the patient?
Clinically, it's always difficult. Clinically, it's always difficult to differentiate those things, because even the gelastic seizure, which are described in hypothalamic hamartomas, they are saying they are not pathognomonic. So clinically, it's very difficult, because anything, even something which is around the hypothalamus, just by compression can give you symptoms like you have something in the hypothalamus. I think you have to differentiate those ones from investigations, radiology, or after a biopsy. Clinically, it's difficult.
Okay. Thanks, Dr. Kabulo.
Thank you.
You're welcome.
Okay, Dr. Kabulo, I'd like to thank you again, and thanks all the panelists. And before we go, Ulrich, you want to make an announcement about the next series, Ulrich?
Yeah, thanks, John. Let me quickly pull the schedule for the next one so that we can all, and I'll share the screen. Okay. So this will be our next lecture series, where we chose neurosurgical emergencies. Now there's a few presenters, as you can see here. If you feel like you want to take any of the presentations, please get in touch, and we can always change this, because a few of the presenters have quite a number of presentations. So from next Saturday, we're going to start with clinical evaluation of comatose patients, and that'll be me. And this is the rest of the presentation. So next week, 6 p.m. Central African time, that's 5 p.m. GMT. I hope all of you will be there. And obviously, thank you, John, for everything.
Okay, well, you know, the series is just...
I have a comment.
Go ahead.
Yes.
It's okay. No, I was just saying, according to this, this is a nice one. So, Ulrich, for me, I'll be just doing like usual. The day I feel like I'm free, I can add a small topic from that presentation. The day I'm free, I can tell you 2-3 days before that, I will add a small slide, like few slides after that presentation.
Okay,
so,
that would be perfect. Thank you.
It's difficult for me to say, you know, I'm in the difficult period. In 2 months' time, I'm writing my final exam in November. So
you'll be okay. We know you'll be okay.
Yes, it's difficult to say put me this day, but I can still come and improvise myself.
Okay.
For your indulgence before.
Okay, thanks, Dr. Kabulo.
Yeah, I'd like to say this. Go ahead.
Yes, and the courage for his exam, we know he's going to ace it.
Thank you so much.
Okay, I'd just like to say that the series that we just completed on neuroanatomy will be available on a playlist, so that you can watch all the videos, you know, one by one, as will the neurosurgical emergencies be put on a playlist that you can even watch from your smartphone. So thanks everybody for coming, and thanks Dr.
Thank you.
Kabulo and panelists.
Thanks, John.
Okay.
Thank you.
Thank you.